Bismillahirrahmanirrahim. We are going to start antepartum hemorrhage, that is the part of obstetrical emergencies for the MCCQE, and we are going to take its brief overview. So what does antepartum hemorrhage stands for? Ante means before and partum means birth and hemorrhage means bleeding. So antepartum hemorrhage is the bleeding that occurs before the birth of the baby or before delivery, and it's usually third trimester bleeding, and it's the bleeding occurring in the third trimester after 20th week of gestation from the genital tract. There are multiple causes of antepartum hemorrhage. Summarizing it, placenta previa, placental abruption, and Vasa previa. These are the main causes of antepartum hemorrhage, that is bleeding after 20th week of gestation. How are these presented? Placenta previa is the painless vaginal bleed. Placental abruption is the painful bleeding. So pain is the main distinguishing feature. In case of placental abruption, there is uterine tenderness, there is pain along with the bleeding, while in case of placenta previa there is painless bleeding. And Vasa previa and uterine rupture, these are the other causes of the bleeding mainly occurring in the third trimester. What is the placenta previa? Placenta previa, as I've already described, it presents as the painless bleeding. It is the low-lying placenta. So placenta usually it is present at the anterosuperior or posterosuperior quadrant. This is the uterus and this is the placenta. In case of placenta previa, placenta is present at the low line or its low lying placenta covering cervical os. Depending on the range of covering, it is further divided into various types like complete placenta previa, marginal, or partial, depending on that whether it covers cervical os completely or it is present at the margin. In case of this placenta previa, there are chances of the vascular rupture as these are present in the placenta, so there is the chance of bleeding in third trimester after 20th week of gestation. What are its risk factors? If there are previous C-sections, multiparity, that is female is having multiple kids, so what is the first step in the management, or what is the key diagnostic step in the diagnosis of placenta previa? So we start with ultrasound. Ultrasound is really important in entire antepartum hemorrhage because it is non-invasive. It tells you about the placental location, it's readily available, it is cost effective. So we are going to start with ultrasound. Digital examination, that is vaginal digital examination, is avoided or prevented in cases of the placenta previa. How we are going to manage these cases? Depending on the condition of the mother and the fetus. If the mother is having hemodynamic instability, we are going to stabilize her first. We are going to start with 2 wide bore IV cannula, or depending on her HB, we can transfuse her, we can stop the bleeding, we can give the her various blood products as well, and we will step towards the C-section if her condition is severe, if the bleeding is much more than the normal, or if she is at term. So keeping this picture in mind, we can clearly see that here placenta is low lying, or it's present at the lower location than normal. What is placental abruption? It is the painful vaginal bleed. In this condition, the uterus is tender and the placenta separates from the uterus. There is the retroplacental hematoma can be over there, and the signs of fetal distress are present, like the fetus is having the blood vascular compromise, or she or he is deprived of the blood. What are its risk factor? Hypertension is the most important risk factor of placental abruption. Trauma, smoking, and cocaine, these can be other causes. Like if mother smokes during her pregnancy, if she is having abuse of cocaine, there are chances of the bleeding, there are chances of hypertension and placental separation as well. Whereas complication, this flow chart, it defines the entire concept of placental abruption, starting from its risk factor leading to its complication and the management. Complication can be DIC, disseminated intravascular coagulation, and the fetal demise, because the chances of hypoxic ischemic encephalopathy, they are over there. The blood supply to the fetus is compromised, and resultantly there are chances of the subsequent death of the fetus. How we are going to manage this patient? We are going to stabilize, we are going to give fluids and urgent delivery if the bleeding is severe or if the mother is at term. You can see from this picture that there is the retroplacental hematoma or the placenta, that is this reddish line. This is entirely separated from uterus. So as this placenta, it contains blood vessels, so blood vascular supply of the fetus is compromised, and the fetal compromise and the hypoxic fetuses are there. In case of Vasa previa, usually the blood vessels or fetal blood vessels, they are present within the umbilical cord. If they are exposed, they are present over the cervical os. It leads to the condition known as Vasa previa. And the most characteristic differentiating feature of this is it is also bleeding in third trimester. It's also the fetal distress, where it's usually present after the rupture of membrane. So rupture of membrane is the most differentiating point here. How we are going to diagnose it? We are going to do the ultrasound along with the Doppler assay to detect the level of the blood flow. How we are going to manage this is the emergency condition, as the chances of the fetal distress are there. So we are going to do this emergency C-section. You can clearly visualize from this picture that this pink color is the uterine lining, brown color is the placenta, and from the placenta an umbilical cord descends and connects to the fetus. So in case of Vasa previa, these umbilical blood vessels, they are not covered and they are prone to rupture. They are exposed and they are present over the cervical os. So chances of the Vasa previa bleeding in third trimester after 20th week of gestation, they are more over there. I have included some MCQ scenarios that actually simulate the actual exam. What is their most important question is, what is the most appropriate step in the management? They are multiple times they are going to ask this, depending on the severity of patient. As we have a female patient, 32-year-old, gravida 3, para 2 women at 32 weeks of the gestation. So 32 weeks represents the third trimester after 20th week of gestation, and it presents with painless bright red vaginal bleed. Painless means placenta previa, and she is hemodynamically stable, means there are no chances of emergency there, and fetal heart rate is assuring. So what is our next step? We are going to confirm our diagnosis by transvaginal ultrasound. The digital vaginal exam, it is contraindicated or it is avoided in case of the placental pathology, because there are chances of rupture are there, and we are not rushing towards emergency C-section as she is stable. We are not going to induce labor as her gestational age is less than 34 weeks. So what is the most appropriate step? It is the transvaginal ultrasound, because it is non-invasive and it confirms our diagnosis. Now there is second scenario, a female patient, gravida 2, para 1, 28-year-old at 34 weeks of gestation, same, more than 20th week in third trimester with severe abdominal pain. Whenever pain is there, it's placental abruption. Whenever there is painless third trimester bleed, so they are going to check you with various buzzword, and the buzzword for placenta previa is the painless third trimester bleed. If there is abdominal pain, then it is placental abruption. In case of placenta previa, there is fresh vaginal bleed, whereas in case of placental abruption, dark vaginal bleed is there, because there are chances of hematoma being there are present, and the uterine rigidity. So fetal monitoring shows late deceleration. What is the late deceleration signify? They represent the signs of fetal distress or fetal compromise or vascular compromise, means that the fetus is deprived of blood. So what is the best next step? As there is uterine rigidity is there, bleeding is there, late decelerations are there, so these are the signs of feto hemodynamic instability. So what we are going to do, we are going to stabilize by giving fluids and prepare for delivery. We are not going to delay this with by giving tocolytics. We are not rushing towards immediate induction because she is at 34 weeks and expectant management is out of question as she is unstable. So we have to acutely manage the patient in order to reduce the damage occurring to the patient and her fetus. These are the take home messages. These are the most important points of these whole antepartum hemorrhage. The causes of antepartum hemorrhage, they are classified into three types. Placenta previa, if there is painless bleed in third trimester, low lying placenta, then it is placenta previa. If there is painful bleed, then it is placental abruption. If the bleeding occurs after the rupture of the membrane and the fetal bradycardia, means fetal distress is there, then it is Vasa previa. What is the first step in the evaluation of this antepartum hemorrhage? So in investigation, in diagnosis of antepartum hemorrhage, whenever they are going to ask you, ultrasound is the most important step because it is non-invasive. Digital exam is usually avoided. So this was the brief overview about antepartum hemorrhage. We are further going to discuss or continue our discussion of obstetrical emergencies and taking their brief concepts in the further files or in further lectures. Thank you.